Good afternoon and welcome to today's edition of the afternoon show. My name is Isa Nu. Today we shall be focusing on the health aspect of Nigerians, most especially when we talk about the issue of the National Health Insurance Authority and then the Act. But then, if we look more into the issue of the NHIS, there are several issues, several complaints that Nigerians have relayed before now. And as at the last time when I had Mr. Martins, AK, who is the program coordinator of Center for Social Justice, he laid so many emphasis on other issues, and I decided to bring him back so that he can give us more information with how the National Health Insurance Authorities Act works. And then, but then let us just take you through this snippet before we continue with our conversation with Mr. Martins, AK. The wealth of any country depends on the health of its citizens. Therefore, any country seeking to develop its economy should strive to improve the health of its citizens so they can contribute to economic development. Health as a social service is very important to the teeming population of any country, as the health sector in any country has been recognized as the primary engine of growth and development. However, healthcare in Nigeria is financed by a combination of tax revenue, out-of-pocket payment, donor funding, and health insurance. Nigeria's health expenditure is relatively low, even when compared with other African countries, and the total health expenditure as a percentage of the gross domestic product from 1998 down to 2000 was less than 5%, falling behind the GDP ratio in other countries, in other developing countries such as Kenya, which is 5.3%, Zambia is 6.2%, Tanzania, and South Africa, which is 7.5%. Limited institutional capacity, corruption, unstable economy, and lack of political will have been identified as factors, while some financing mechanisms of financing healthcare have not worked effectively. Insurance is a risk transfer mechanism in which the insured makes small periodic payment called premiums to another in return for the payment of benefits packages on the occurrence of a specified event. Therefore, health insurance involves the pooling of health risks and funds. The National Health Insurance Scheme in Nigeria was designed to provide minimum economic security to workers with regards to unfavorable losses resulting from accidental injury, sickness, old age, unemployment, and so on. It is based on a prepayment system where both the employer and the employee make contributions to the scheme, and the employee accesses the scheme whenever he or she is ill. The scheme was officially launched on June 6, 2005, and services to enrolls started later in 2005. According to Ose Brown, 2013, over 4 million identified cards have been issued, and then 62 HMOs have been accredited and registered, and more applications are being processed currently. But then these are basically on the old data. Definitely there have been a series of changes that have taken place since the establishment of the NHIS, and we've seen improvement, yes, in some of their services, but there's still, the complaint is still there on how effective the services will be to Nigerians. So we'll go on a very short break, and when we return, we start up with a conversation with Mr. Martins, AK, the program coordinator for Center for Social Justice.
Our first efforts at democracy and self-government were abruptly arrested in the mid-60s, largely as a result of the incongenial atmosphere engendered by the uncompromising stance adopted by the political parties of the First Republic. Thus, opportunities were lost for our people to interact and learn to accommodate different points of view for the betterment of the country. We must not allow that episode to repeat itself. The new system that we have adopted presents us with yet another opportunity to achieve national integration, which is a prerequisite for the building of a strong and virile nation.
5 FM Abuja. Also television, DSTV channel 392, Star Times Terrestrial channel 127, Free TV channel 507, People's TV channel 285. And
welcome back from that short break, and still with us here in the studio is Mr. Martins, AK. And before now, I did inform you that yes, our focus will be on the issue of the NHIS, and definitely there are several issues. Mr. Martins, good afternoon and welcome to the afternoon edition.
Good afternoon, sir. Nice to be on the show.
It's important that I had to bring you back because after the last program, there are several calls on people trying to understand still the effectiveness of the NHIS. And looking at everything that is happening now, people talk more about the issue of the National Health Insurance Authority Act. What is this all about?
Okay, so what we used to have before is the National Health Insurance Scheme Act of 2004. Now, from that time when the scheme started, the act is 2004 till late last year, till sometime last year, we were not getting as much enrollment as we should. So that means certain things needed to change. So it is on the basis of that the enabling law establishing the NHIS, National Health Insurance Scheme, was changed to National Health Insurance Authority Act. So it now National Health Insurance Authority Act. So it has been upgraded from a scheme to an authority. So in May 2022, the then President Muhammadu Buhari signed the law. Right, so it became a law, the NHIA Act, and then the key provisions of that act that separated it from what it used to be when it was a NHIS.
Yeah, scheme.
When it was the National Health Insurance Scheme. A few things, but most importantly, are things like the compulsory nature of health insurance. So by provision of the new law, the National Health Insurance Authority Act, health insurance is now compulsory in Nigeria for every resident of Nigeria. Once you are living in Nigeria, health insurance is compulsory. That is the position of the law. Meaning if you don't have a health insurance coverage, you are actually running foul of the law. But that's by the way. The second key thing, the standout thing in the National Health Insurance Authority Act is the establishment of the Vulnerable Group Fund. Because we could say health insurance is compulsory, we could ask people to, come on board and take up a health insurance package. But the truth is that there are people who cannot afford it by virtue of their financial and economic capacity or whatever challenge they have. They cannot afford it. So the government has to provide for those kinds of persons, those categories of persons. That is why the Vulnerable Group Fund was set up. So that fund will be the source of providing the health insurance coverage for persons who are vulnerable. Another key thing which the National Health Insurance Authority Act established is a proper recognizing of the state's health insurance agencies. We used to have a situation where it was just national that was doing everything, NHIA, national, even providing services at the lowest level. And maybe that was why it was not enrolling as much people as it should. So it was thought that it would be good to give the state the power to also do what the national is doing, right? So we now have the state health insurance agencies being properly recognized and integrated by the National Health Insurance Authority Act. So also the head of the agency now is now an MD, the managing director, unlike when it used to be executive secretary under the NHIS era. So this gives more powers, right, than what it used to be. So generally, when all these things have now been captured in the law, you can no longer use the previous guideline for NHIS to actualize these new provisions. So when we had NHIS, National Health Insurance Scheme of 2004, we used to have National Health Insurance Scheme Operational Guideline of 2012. So So now that the law has changed to NHIA Act of 2022, it now makes sense to bring an operational guideline that will reflect the things that have been, captured in the new act. So it is based on that the National Health Insurance Authority reached out to stakeholders. They published in the newspapers asking stakeholders to make submissions, technical inputs. People submitted memos. Stakeholders were brought together. Of course, NHIA on its own also had its own internal team that also came up with like a zero draft operational guideline. Okay. So when what stakeholders submitted was merged with what they had come up with in-house, right? They now had a committee that harmonized everything, and the committee was very rich. You had people from the academia, people from civil society, people from government, people from private sector. All manner of relevant stakeholders were brought on board in that committee. So when they now finished, they now had the NHIA operational guideline 2023, which hopefully will be able to drive the provisions of the NHIA Act. So the guideline is a secondary document emanating from the NHIA Act.
But you call it Act. Was it that the former president assented to it?
You mean President Buhari?
Yeah.
Yes, he did. Precisely on May 2022 was when he signed it.
So now it is for the National Health Insurance Authority
Act.
Yes. Okay. But then moving forward now, what are the technicalities that have actually changed in the whole of this process?
Well, so if you look at what it used to be before, the NHIA was finding it difficult to do enrollment at the state, because you're now asking national to be doing enrollment at the state level. There were lots of challenges, and probably that was why the enrollment figures were low. So to address that, we've now had a situation where the NHIA has now created the state social health insurance agencies. So every state now has a social health insurance agency, right? So that social health insurance agency for the state will now drive the interventions of the National Health Insurance Agency in that particular state. So instead of having national do everything, even at the state level, we've now had the State Health Insurance Agency driving interventions in their own state. So everybody can then go back and make your law. Every state can then have its own State Health Insurance Agency law that will reflect the peculiarities in that particular state. However, your state health insurance agency law is not expected to be at variance with the federal law, because the national law has said, for instance, health insurance is compulsory. So it should just trickle down to all any state that makes its own voluntary is, that part of the law cannot stand because it has violated the parent law and all of that. So that was a key challenge. And then it makes it interesting because it gives every state the ability to make a law to reflect its own peculiarities. For instance, in some states, especially in the far north, right, people believe that you cannot insure your health. More or less, it is God that insures. So for that purpose, in some of those locations, the agency is called the State Contributory Health Management Agency. So you are contributing for this agency to manage your health, right? In some other places, it is called the National Health, the State Health Insurance Agency, if they see it as such. In some other places, it is called the Contributory Health Protection Program. So every state has that ability to tweak one or two things to reflect its own peculiarity and hopefully get more enrollment.
Okay, I can see that even in Kaduna, it is that of the contributory that they adopted. But then, if you look at these terminologies and then people try to understand the whole system, has it been better off since when the states were bonded with the federal to see that, yes, they get enough persons to be part of it?
There's been an improvement. Huge improvement. Remember, the reason why it had to be unbundled now was because we were not getting enough enrollment. So the states on their own are now driving that process. There has been a huge improvement. Since the states, started leading the intervention, the percentage of Nigerians who have enrolled into the scheme has increased, right? So the figures keeps on changing every day because people are enrolling every day. But I know that we are now hitting around 10%, right, in recent times, unlike what it used to be when it was just hovering around 5% or thereabout. So, but then the interesting thing is that different states are moving at different rates. There are some states you go to, the State Health Insurance Agency has been in operation for maybe 2 years or thereabout. Their structures, the law, the enabling law, the structures, the human resource, even the actual enrollment process has been on for 2 years or thereabout, maybe some 1 year and maybe some less. And then there are some other states you go to, they have an enabling law, but the institution that will implement the enabling law has not been actually activated. So we are seeing a different, outcome or different productivity and results in different states. A state like Adamawa, for instance, they are doing so well in terms of the actual enrollment of persons. That's the state into the state, the state health insurance scheme. So for a state like Adamawa, they are doing so well. The numbers are encouraging, and it's good. So we are seeing an increase in there. In some other states, it's not so wonderful.
But then if you look at the role of the federation now, we talk about 30 states, including the FCT. Is there a particular state that don't have this scheme in one way or the other?
So okay, so what is the process? First, you need an enabling law, right? To the best of my knowledge, everybody has an enabling law. They've all set up the law, right? It is compulsory. In fact, the Basic Healthcare Provision Fund has a window, right, to provide resources to the states for health insurance services. So part of the conditions to benefit from that is that you must have the enabling law. Right? Beyond the law too, there are some other conditions. But I think at the stage of the law, I would say every state has it. But beyond establishing the law, the next thing would then be to set up the agency, appoint the executive secretary of the agency at the state, get a functional office building, hire staff, right? Give them the infrastructure, the technology support, the ICT that they need, and even the financial empowerment that they need to actually start working. So at that level too, most states have crossed that stage, except one or two which I don't want to mention names now. And then maybe by the time you go beyond that, you then see higher levels of the actual enrollment of persons to come and receive those services. So like I said, some states are doing more than others. Some have hit more than 100,000 enrollees. Some are still struggling with 10, 20, 30,000 and all of that. So different realities in different states. And then there are some other things too around the vulnerable group fund, activation of the fund in that particular state. So different states have different realities. And then something like, the organized labor.
Yes.
Yeah, they really need to come on board at the state level for the state health insurance scheme to function properly. Because the thing about health insurance is that the more the merrier. When more people are contributing into that common pool of funds, it means that the pool of funds will be huge. There will always be money in that pool of funds because many people are contributing. So if somebody falls sick, goes to the hospital, receives service, we are sure that there is money in the pool, right? And one thing that guarantees huge amount of resources in that pool is when you're able to bring the state civil servants on board, because some states have civil servants in thousands. So if you're able to bring your state civil servants, depending on the number, you could have brought maybe 10,000 persons into the scheme at once, right? So it gives a large, pool of funds. So we see situations where, of course, it's contributory. The state civil servants have to contribute a certain percentage of their salary to it. So we see situations where deductions were made from the salaries of the state civil servants for the provision of the health insurance service, and for some reasons the government did not provide its own counterpart, its own share or percentage that should be provided. So we then see situations where the person who has been, money has been deducted from his salary eventually goes to the hospital and cannot receive the service because the state has not brought its own counterpart. It takes two to tango, and then before you know it, it becomes a problem. The organized labor in the state can then start complaining that, you've been deducting our salaries for so and so number of months. We've now gone to the hospital to receive the health insurance service, and we are not getting the service. So it becomes a problem. So in some states, that is actually a challenge which is ongoing there. But in some other states, they've been able to get organized labor, the NLC in the states, to come on board, support the process, and the state government too, is being loyal and faithful through by bringing its own share of the contribution. So everything is working perfectly in some states.
So in all of this now, one major key player in this particular system is the HMOs. And the HMOs, what role are they playing now under this particular act?
So, the individual who wants to receive service, who is sick and needs service, is on one side. The health facility, the hospital that will deliver the service is on the other side. So the HMO is the middleman between the individual who needs the service and the hospital that will deliver the service to the individual. So what the HMO does is that it receives money, right, from the individuals. The individuals pay to the HMO, right, and then the HMO gives the individual the opportunity to choose health facility, hospitals that he or she is comfortable with, maybe close to your residence or whatever criteria. But
are you paying to the HMOs, or this salary, the money is being deducted from your salary directly, and if it is deducted from your salary directly, it goes to the government coffers, or where does it go to?
Okay, so in the case of the private establishments, right, people in the private sector, they do make the payment straight to the HMO.
Okay.
Right, for those in the private sector, they do make the payment straight to the HMO, and then the HMO then takes the money to the health facility. It's now called the capitation. So the capitation is the amount of money that the HMO takes to the health facility on behalf of that client, whether he or she falls ill or does not fall ill. Yeah, so that is the way it works. Then for those in the public sector, for those in government, they still have HMOs in charge of certain ministries, right? So if you go to Ministry of maybe Agric, for instance, there could be a particular HMO that is in charge of employees of Ministry of Agric. So that HMO, right, also receives the money and then transfers to the hospital. Different government establishments have different HMOs. I know there's police HMO. Yeah. So those one is specific for police. If you go to the military area, they also have certain HMOs that handle their own operations. Meaning the National Assembly too.
Yeah, I think they have. Yes. But if you look at the role of this, and then you come to realize that having these HMOs seem not to be a very bad idea. But then the issue is that how effective are these HMOs? Before I answer that question, there's one thing that just tickled my mind now with respect to the number of persons that are registered under the private HMOs and that of the government. Which one seems to be a bit more?
Okay, so I will start with the effectiveness of the HMOs. Okay. Yeah, it's best practice to bring the HMOs on board, right? It's best practice to bring them on board, and because there's need for that middleman that link between has to be there. So it's good that the HMOs are there. And now with respect to effectiveness, you see sometimes it depends on the sincerity that things are being done with. A situation where, let's say I'm a key high profile stakeholder in government, right? And I'm not into this health insurance business, but because I'm a key stakeholder in government, I go and register a HMO, right? And then I say all the staff in Ministry of Agric, Environment, Education, Transport, all of that, you people will use my own HMO. Because most times the staff may not even get the opportunity to choose which HMO they would use, because a particular HMO has been assigned to that particular ministry, right? So if it happens that way, so for the key government official who is just trying to make money, he registers the HMO, which probably does not have capacity, and then everybody in so and so ministry now comes to that HMO by force, compulsorily. So for him, it's all about business, because in the first place, he probably didn't have the capacity to deliver on that mandate, but he used his position to ensure that so and so number of persons come to his HMO. So under such circumstances, the efficiency of the HMO will be questioned. The HMO may not deliver because it probably even didn't have the capacity to do so. And when we have these challenges more, are HMOs that manage employees in the government sector. Now, there are some HMOs that the bulk of their enrollees come from the private sector. So maybe those ones, permit me to say, they were not so connected to get the free pie that you can get from government. So those ones, they now have to go to the field by themselves to market their products, send their marketers to the field, like the way the banks do, to get persons to come on board. And generally, I would say that those ones that get the bulk of their enrollees from the private sector are probably more effective than the ones that get the bulk of their enrollees from the public sector. So that is just a general overview. But then I would say different HMOs have different levels of performance based on the capacity and the technical know-how and the human resource that particular HMO has.
Okay, moving forward again, there's one key aspect of all this, because I've seen that in there are certain hospitals you go to and then you still have this problem for you to be able to access the HMOs. Probably if you want to get drugs or maybe on emergency, those kind of the process to fasten your health issues will be a bit delayed, and these are critical issues that if you're having health issues, you shouldn't stay long before you get the necessary attention. But we've seen situations on several counts where people raise questions on how effective the HMOs are. But then when it comes to the issue of transparency, how do you think they work transparently in such a way that it favors the users of these particular facilities?
So that is where the National Health Insurance Authority comes into play, because it is the National Health Insurance Authority that is regulating the HMOs. No HMO can just start operation except you have been accredited by the National Health Insurance. Have there been anyone that has been sanctioned as? Yes. Okay. In fact, they do accreditation and re-accreditation. They do it periodically. So after some time, you come back, all the HMOs will come back to NHIA for re-accreditation. So if the NHIA feels that this particular HMO is not meeting up to its expectations, is not delivering in terms of the quality of service, NHIA can refuse to accredit that HMO. There are instances where that has been done, and it is within the powers and authorities of the NHIA to deny any HMO accreditation. And if that happens, then that HMO can no longer function. Even the NHIA even has a way of controlling the scope of where you can get your enrollees from. So general regulation of the HMOs lies with the NHIA.
Okay, as a civil society organization, what are your concerns presently with respect to this particular act?
My biggest concern is enforcing the compulsory nature of the act, because the act has clearly said health insurance is compulsory for all residents of Nigeria. Then how then do you make it compulsory? Right? How? Because if something is compulsory, it means if I don't have it, I have fallen foul of the law. And like I said, the numbers of persons who have been enrolled is hovering around maybe around 10% or thereabout. So it means that about 90% of Nigerians are actually in violation of this law as we speak. So how then do you enforce a law when majority of your citizens
Are corporate.
Mind you, the majority of the citizens don't even know that it is now compulsory. So if you want to penalize me, you are penalizing me for something I didn't even know is in existence. So my biggest challenge is we can't just make a law, right? And then implementing that law then becomes a problem. It's just like saying you are placing a ban on open defecation. Meanwhile, majority of Nigerians don't have access to toilets. So your anti-open defecation law cannot deliver. So if you are saying health insurance is compulsory, meanwhile majority of the persons in the country don't know that health insurance is compulsory, don't even know how to access the service, then it becomes a big challenge. So my biggest concern is how will the NHIA be able to trickle down the message, the sensitization, the awareness for everybody to come on board? Because the truth is that it is in your own interest to get a health insurance coverage. No, you are not doing anybody a favor. It is in your own interest. But because there is no enforcement, it becomes a problem. Now, if you buy, even if it's a second-hand car, and you drive the second-hand car on the road without vehicle insurance, police, road safety, VIO, and co., they will arrest you for not having insurance for your car. Do you understand? And you will pay fine. Now, between your car and your health, which is more important? Your health. So if you are able to insure your car, nobody even needs to tell you to insure your health. But there's nobody enforcing health insurance. So everybody is just relaxed. My biggest challenge is how do we ensure that every resident of Nigeria gets health insurance coverage because we have been told it is compulsory. Okay,
that's Martins AK giving us some issues and raising questions on the effectiveness of the not the NHIS this time, even the HMO you added, because that is where Nigeria seems to be complaining more about. When you go to the hospital, you don't get the kind of service that is needed. And I'm happy that you stated it clear that the NHIA always play that supervisory role to make sure that yes, Nigerians get the best of healthcare. So we'll be going on a very short break now, and Martins is still here with us, and then we'll be here to definitely complete some of the questions that Nigerians are asking with respect to the NHIA Act.
Whose assignment is not only to revive the stature of man in Africa, but to restore the dignity of man in the world.
Come back from the break, and still here with us is Mr. Martins AK, the program coordinator for the civil society group known as Center for Social Justice. Most especially, whenever we bring him up, is basically for him to enlighten us more on issues that pertains to health and how it is also affecting Nigerians. And we have been discussing several issues on this particular platform with respect to health. And Mr. Martins AK is still here, and I would like you to just throw more light on this particular issue, whereby there is inequality in the distribution of healthcare facilities between the urban and rural areas when it comes to the issue of NHIA now.
Well, the issue of inequality goes beyond the distribution of health facilities. Of course, that is why there is inequality in the first place. It also includes things around education and all of that. So, but having said that, it is something that should be addressed. It's not right. It's not proper. It doesn't help the overall health development of the state or the nation at large. It is something that the authorities, those in government, already know that something has to be done to address it.
Yeah.
Because a situation where somebody is sick in a rural area, he does not need to go to local government headquarters or the state capital to access a health facility. You should be able to access a health facility in your immediate locality.
Yeah.
That is actually what universal health coverage is all about. That is actually what strengthening the health system of a particular country is all about. Health facilities should not be distributed based on financial capacity of citizens. Of course, even the National Health Insurance Authority Act is actually geared towards addressing some of these challenges, because there is a vulnerable group fund that has been created by the National Health Insurance Authority Act, and the vulnerable group fund is supposed to focus on the vulnerable persons, more like providing for the health insurance services of the vulnerable persons. So that means there's also a target for persons who are on the negative side of the inequality divide. And we hope that the process of selecting health facilities that will provide basic healthcare provision fund services will be such that persons in very rural areas will also receive maximum benefit and maximum access to health facilities. So those in government, I believe, are doing their best to address the inequality in distribution of healthcare facilities in the state.
Do you think there will be there is this particular issue that normally affects most of government policy with respect to tradition and culture? Just like you earlier stated that in some states they term it as contributory. Is it contributory? What
health management?
Health management,
yeah.
And then in some other states where they see it as NHIA. In this particular case, there are certain places you go to. They'll still tell you that, look, now that the government has made this thing compulsory for everybody, their culture or their religion doesn't really accept that they do some of these things, or they go to a hospital. There are certain people that even don't believe that, yes, the hospital is not even the best place for them to get the best care. So how can you put this straightforward in such a way that, yes, Nigerians can, those that have this particular thinking, can readdress their mindset and then take advantage of this particular law that has been put in place? So
the truth is that everybody falls sick, both the highly religious man and the one that is not religious. Everybody falls sick, and we all need medical attention to recover. Nobody would say he does not need a health facility to recover. People need health facilities. People go to hospitals to recover. So one thing we do is, in places where we go for interventions, we ask the religious leaders in those places to talk to the community members by themselves. So by the time you see your imam or your pastor or your reverend father telling you the need to go to hospital and get a health insurance service, then it convinces you that, okay, fine, it means that my religion allows it because it is my imam or my reverend father or pastor that is telling me this. So the strategy is to use religious leaders to pass the message, the traditional leaders, because many of them are well respected. People listen to them. If the traditional ruler says, go to the hospital because I have gone, people then listen. So what we do is use influential opinion leaders to pass the message across, so that by the time these religious leaders talk to their followers, then the followers will no longer have a basis to say I shouldn't go to hospital and all of that. So it's something that everybody has to come on board to see that we kill that mindset of God will deliver me. I don't need hospital.
Indeed. It's very important, because there's this particular aspect of it again that is very, very important. For instance, if you go to Bayelsa State or River State, there are some riverine communities that are far from the reach of what they have in the cities or town. And as a civil society organization, how have you been able to push to see that, yes, irrespective of the differences, they should at least get the attention of the government to see that, yes, they benefit from this particular act?
The government is aware that those people are there. During elections, election materials.
But that's
Election materials get there,
yeah.
and they do vote. So it means that government is aware that they are there, and government, I believe, tries to provide services for them. So civil society organizations, you know, if they are able to access those places from time to time, should, you know, keep on talking to the people there, and, you know, play every role and sacrifice whatever you need to ensure that the message gets to those people there.
Thank you so much, Mr. Martin Seki. It's nice having you discussing the NHIA Act, and definitely Nigerians will become more aware that yes, it is important that everybody should register in this scheme, be it at the state, at the federal level. Only the local government now, we don't know much about them, but I know in the local government we still have the primary health centers. I don't know if they also if they've adopted that same practice, but then definitely we invite you one more time to give us more explanation on this. This is how far we can go today on the afternoon edition. My name is Isanu. Have a wonderful day and stay blessed.